years since the last time we spoke, there's now a large phase 3 randomized study that's going to take place looking at the utility of these drugs in patients whose tumors have these DNA repair defects. So the second part of what I wanted to touch on was another aspect of what came out of that big study, the Stand Up to Cancer effort. So you've heard about immunotherapy at a session earlier. So the idea is, can we make the immune system recognize cancer and get rid of it, right? So when we talk about immunotherapy, there are so many aspects of the immune system that are really important, and even I get incredibly confused about how these things interact. So when I talk to you about PD-1 and checkpoint inhibitors, I'm going to be very simplistic about it. So I think about the T cells, which you heard a lot about from Dr. Riddell and Dr. Schweitzer, sort of like the TSA. That is, they're monitoring for the good guys and the bad guys, and they're not perfect all the time, shall we say, okay? So the idea behind TSA is somebody steps up to the podium and they give them a passport and they say, okay, you look okay. They look at them, they don't have any smoking bombs in their underwear or their shoes, and they say, okay, you can get on the plane, right? But if somebody shows up and they don't have their passport and they've got something else going on that they can recognize as bad, then TSA does its job very effectively, right? But it's a bit of a superficial check, okay? So the idea here is that the passport, so cancer cells are not picked out by the immune system often enough. We know that, otherwise cancer would not actually occur. Your immune system would always pick it out. So the passport for a cancer cell that allows it to get past the T cell is something called PD-L1, okay? So that's the passport. So you can imagine that if you could take that passport away, then the T cell might recognize it much more readily, okay? So the idea here is that all these immunotherapy drugs are trying to block this interaction between PD-1, which is on the T cell, and PD-L1, which is the passport on the cancer cell. So if you block this, then the cancer cell becomes immunogenic. The other part is there's something called mutational load. So Dr. Schweitzer mentioned it earlier. So the idea is the mutational load is sort of like the extra thing that tells the TSA there's something bad going on, okay? Sort of the smoking bomb in somebody's underwear. So the idea here is that high mutational load cancers, kidney cancer, lung cancer, and melanoma, are all high mutational load cancers, right? So that's why these immunotherapies have been very effective against them, because they have all these other signs that the immune system can use to recognize them as aberrant. Now, the early studies looking at these PD-1 inhibitors in prostate cancer were not very effective. In the first studies done with these drugs, 17 patients with prostate cancer were in those studies, and no one responded. But now that this idea of high mutational load is more relevant, because we know that that actually predicts for things, is there a high load cancer that might be predicted to respond? And the short answer is yes. So from some work done by Colin Pritchard, who actually I don't think he spoke this time, but he has spoken in previous IPCR symposia, and Dr. Nelson, they found that in a number of prostate cancers, somewhere in the range of about 10 to 12%, it has this hypermutated phenotype, meaning that the DNA repair mechanism, mismatch repair, it's inactivated by mutation. And so they have this incredible number of DNA repair deficiencies and very high mutational load that would actually predict for response. And I'll tell you why. Because there's actually been a study, again, in the last year, showing that these PD-1 inhibitors work very well in tumors that have mismatch repair. So in this study, which was published in the New England Journal of Medicine, which is our most high-profile journal, this group at Hopkins said, we're going to treat colon cancer is where most of this happens, the mismatch repair abnormalities. We're going to treat men and women with mismatch repair, without mismatch repair, and then we're going to actually enroll some other people who have mismatch repair cancers that aren't colon cancer and see how they do. And so this is sort of, again, the money shot from that study. So B, over there on the left, the line on the top is how people did who had mismatch repair deficient tumors treated with the PD-1 inhibitors compared to the people who had mismatch repair that was normal. And clearly the response and the survival was much better in the patients who had the mismatch repair deficient tumors. The sample on the right-hand side of your screen is those non-colon cancer tumors that had mismatch repair deficiency tumors, and they had, you know, for a group of patients who basically had burned through all their various therapies, they were 80% of them were alive a year after they started on the therapy. That is unheard of, okay? So, how is this relevant to prostate cancer? Well, here's one example. Again, another story. Again, this is personalized medicine, so I don't want to make this too much of a granular story on any individual, but that's the whole idea of precision medicine. That's why we think this is important. So this is one of my patients. He was on hormone therapy until about 2014, where things started to not work so well, and he participated in the Stand Up to Cancer effort. He started on abiraterone, enzalutamide. Those both kept things under control for a prolonged period of time, and then things started to change. PSA continued to rise despite docetaxel. We did actually get his sequencing results back, and I'll show you those in a moment, and there was a hint that maybe carboplatin might help. He then got cabazitaxel, and everything was going sideways. So about the time he got this therapy, CBZ, you can see on there, he was in the hospital, critically ill, actually on a ventilator at one point. But we knew that he had this hypermutated cancer as a result of the sequencing that had been done, and so we gave him a PD-1 inhibitor essentially while he was on the ventilator. And you can see what happened to his PSA that had been rising for the last year and a half, is that finally it went down. He is now out of the hospital, walking around, doing, you know, he's not certainly back to his baseline, but he's getting there. And that is clearly a result of this new PD-1 inhibitor therapy that was given to him based on the sequencing that we knew made some sense. So this was his sequencing result. This is a typical sequence analysis from any individual prostate cancer, and the relevant point of this is this part, which is this hypermutated sample. So he had a mutation of one of these mismatch repair genes called MSH2, and the other one was knocked out in the cancer, and so he had a hypermutated tumor. So this, again, is an individual story about how these sorts of personalized medicine approaches might provide us with better approaches to treating patients. Now, this is just the beginning, okay? All these other abnormalities were found in the Stand Up to Cancer effort, and that was only the first 150 patients. We got another 350 patients to go through in terms of their sequence. This is just the beginning at being able to change outcomes for men. So we locally are also trying to double down on these abnormalities. So we're very invested in these DNA repair defects, and so we have studies going on, or starting up, using these PARP inhibitors with and without chemotherapy. And we're very interested in talking to patients whose families have very strong histories of breast and ovarian cancer, or actually are known to have BRCA mutations, because those men are definitely people who can benefit from this new class of therapy that we're talking about. Dr. Schweitzer has designed a study that is still in startup for treating hypermutated prostate cancer with these PD-1 inhibitors, and you heard him talk about that a little bit earlier. Dr. Nelson isn't going to talk about this, but he's really responsible for figuring out, in fact, that somewhere in the range of about 10% of all men with advanced prostate cancer have inherited their propensity to have these DNA repair deficiencies, and we can hypothetically pick those men up, these abnormalities in their tumor, just by checking their normal DNA. So there are efforts. There's actually a study open right now over at the VA, where I'm doing some research, doing germline testing for every man in our VA for these abnormalities, so that they might benefit from PARP inhibitors and platinum agents. And we're working on getting the funding and support to do this for the entire state of Washington. That's what we would like to do, because, again, we think that we can give access to these therapies to men that could benefit from them today. And finally, a lot of people here and elsewhere are looking at new ways of figuring out how to find these deficiencies without having somebody undergo a biopsy, just by checking a blood test and finding what's called circulating tumor DNA. And maybe we can talk about that in the discussion session. So that's some of what we're doing. It's very exciting, because we're finding ways to personalize therapy for every individual, and that's obviously what we'd like to do in the next tomorrow, let's say. So
Thank you, Dr. Montgomery. So continuing on with these individual examples, and I think once we get to the discussion point, we'll talk about how commonly these occur, how frequently they occur. We're very hopeful that the anecdotes that we present will lead to more generalized therapies. Right now it is very individualized, so we know, for example, that 1/5 of men would have these particular defects, but what about the other 80%? And I'm sure you're thinking about that and asking that. And so we can talk about that. I'm going to give you one other perspective, a patient's perspective, really. He couldn't be here today. This particular individual lives in Wenatchee, but came to us for an evaluation, for a consult, more than a year ago, I think probably closer to 2 years ago, as he was running out of some options for his therapy. He had advanced metastatic prostate cancer and could kind of see where things were going. And I saw him in clinic, as you'll see, and we talked about obtaining a tumor biopsy to see if we could find something that might be useful for him. And there were some surprising things, actually, that emerged that perhaps in retrospect weren't quite as surprising as they turned out to be. But we'll give you this video and talk about it afterward.
If we hadn't come here to meet up,
Hello. Hi. Good to see you.
I don't know what would happen.
Here at the University of Washington and Seattle Cancer Care Alliance, we often see patients for second opinions regarding how to manage their cancer.
Todd Raymond was diagnosed with prostate cancer in 2004.
This diagnosis and treatment journey that I've been on has been probably the most enlightening experience of my life.
The diagnosis came kind of intrusive.
He underwent radiation, hormone therapy, and chemotherapy in his hometown of Yakima. But one after another, each of those treatments stopped working.
I did the beginning, I had hopes it would be curable, and the hopes were dashed in 2008. We were on watch for waiting, and July 1st, 2008, he was diagnosed with metastatic stage 4 prostate cancer. And I realized that cure was not possible. So I tried to concentrate on treatment.
Todd and his wife Helga wanted a second opinion. Their daughter had recently graduated from the University of Washington.
What motivated you to come here?
And she recommended Dr. Peter Nelson, a professor of medicine at UW and a medical oncologist at Fred Hutchinson Cancer Research Center.
He cares about his patients,
He has compassion.
and I really respect that.
Raymond's tumor was biopsied, and his DNA was sequenced as part of a treatment often called precision oncology or precision medicine.
Rather than using one-size-fits-all type therapies, rather than using fairly generic therapies, but the whole point is to try to tailor a treatment based on what the underlying genetic aberrations might be in their tumor.
I thought it was great because that gives us another way to maybe target instead of doing the shotgun approach of chemo.
In his case, there were two important implications. First, it immediately told us what treatment he should have for this tumor.
The other discovery, Raymond had an inherited mutation of the BRCA gene. In men, it increases the risk of prostate cancer. In women, it increases the risk of breast and ovarian cancer.
So then the question is, well, did other family members inherit it?
With our daughter, we invited her to Yakima and told her it's not the conversation you expect to have with your children. Please get tested. You might have a higher population of babies.
Alicia tested positive for the BRCA gene, which puts her at a higher risk of developing breast cancer. Now she works with her healthcare team to make sure she is frequent screenings.
Prostate cancer passes from father to son, but as our daughter showed, the mutation can go from male to female. And I've also heard it can skip a generation and then show up like with the grandkids.
But Todd and Helga decided not to tell their son right away. He was a UW student, but he was studying in Europe for a year. Soon after he came home, Todd broke the news.
And he told Alexandra, I was not home. I'll let him do that.
Well, it's not a diagnosis of cancer, it's just a possible risk factor. We don't even know yet if he's positive. He still needs to know it so that he can be with it and deal with it and come to terms with it himself.
And we will do the test. If I have to drag it, then
Todd is now on a PARP inhibitor, which prevents the cancer cells from repairing themselves. It's a medication typically used to treat ovarian and breast cancer, but Helga convinced the drug company to make the medication available to Todd, even though it hadn't been approved for prostate cancer.
Since it is the same defect that's in the breast cancer, that's in the ovarian cancer, the idea it should work, and they pursued it, and they even has to.
people ask me what I want for Christmas, and I said, a PARP inhibitor.
Dr. Nelson says Todd is responding to treatment. The Brahmans are ready to face whatever the future holds, a future that gets brighter with each medical discovery.
Each year, our basic understanding of what drives cancer has improved dramatically, and now new therapies for some cancers are making huge impacts.
All right. So you get the idea. This isn't going to be for everyone. We know already it will be effective for a subset, just as you heard the immunotherapy is now very effective for certain types of leukemia and lymphoma. What we're realizing is we're gradually chipping away at this. We're identifying some tumors with certain vulnerabilities where we can devise a particular therapy in a particular pathway. We can almost always tell you, if we look in the tumor, why that cancer developed, what the drivers of that cancer are. But for many of those drivers, we don't currently have a therapy. We recognize what we need to develop a therapy for. For example, one of the most common mutations, drivers in all of cancer is a gene called RAS, R-A-S, very common in lung cancer, head and neck cancers, and we've never had a therapy that could specifically target RAS, for example. So the National Cancer Institute currently has a huge project devoted specifically to targeting that one cancer driver. So we can recognize what's occurring in prostate cancer and direct our efforts toward developing therapeutics that will target those drivers. So our last talk of this session before we open it up for the last QA is by Nola Klempus, who's our, as I mentioned, the project manager of the Institute for Prostate Cancer Research, and she's going to tell you about this effort that we've launched throughout the state of Washington called Empower Northwest. Nola?
Hi, everybody. It's a pleasure to be here today. I'm here to talk about the Empower Northwest project, which is designed to be a repository for the quality of life and the treatment outcomes of prostate cancer patients across the state. So actually, if you remember last year, I was here talking about our plan to build it, and so I'm really excited to be able to come back and show you guys actually a preview of some of the data that we've collected in the last year. So to remind you of kind of the concept here, I don't think I need to tell this audience that prostate cancer is a big issue. It's a big issue not only personally in your own lives, but it's a big issue across the world. So there are hundreds of thousands of men that are diagnosed with prostate cancer every year, and it's estimated that there are 3 million men in the United States alone that are currently battling prostate cancer. So what that means is that we have a lot of men out there, but each one of them holds really valuable information. They have information about the kind of treatments that they've experienced, and also information about the kinds of side effects that they've experienced. They also have information about their clinical outcomes, how aggressive their disease was, their family history, All of these things are crucially important to help us understand at a population level what's really happening with prostate cancer. Today, that information is sitting there and it's not being used. Our concept is, wouldn't it be valuable if we could start to collect this information, systematically collect it, understand it, curate it, and be able to use that information as not only a decision-making tool, but also to drive quality improvement in treatment for everyone. So that's what we're doing. So we're collecting that data, and the idea is that we can start to group men with similar experiences, with similar types of clinical factors or treatment factors, to really be able to start to predict for the next man that comes up who's diagnosed, what is your chance of cancer relapse with treatment A versus treatment B? What is your chance that you're going to have a side effect or anything? So the question is, how can we use this information to really be valuable to patients, researchers, as well as the entire community that really cares about prostate cancer? So the idea is, again, so when someone's diagnosed, they aren't making this decision by themselves, but we're learning from everybody else across the state and the world how best to give them the best possible outcome that we can, given the data that exists out there. And also, we really want to be able to use a data-driven approach that factors in personality, preferences, lifestyle, because as we all know, a lot of these treatments for prostate cancer are very personal, have personal outcomes in terms of your quality of life, and we want to be able to make that a decision that is as well informed as possible. So again, that's what Empower is really about. Again, we've had men fill out a survey, either online or in hard copy. I do have copies of the actual survey here today. We launched in January, and to date we've had about 300 men participate. So now we get to dive in and start to look at some of the data. You guys excited? Okay. So as of now, of those 300 men, 94% have localized prostate cancer. So right now, we're really not sampling the metastatic population yet. I'm going to be putting in lots of plugs that I want more people to fill out the survey because we really want to be able to have access to a more robust data set. But the question is, okay, of those men with localized disease, what treatments did they have? So this is a breakdown. The overwhelming majority of people in our registry had surgery, 55%. That's represented by that 130 number in the pie chart. 16% are on active surveillance, 10% had brachytherapy, and 10% had external beam radiation. So something I want to draw your attention to is that in this pie chart, some of those pie slices are getting pretty thin. So that means that we didn't have that many men who had that particular kind of treatment. So I'm going to put in a warning, okay? This is draft data, this is preliminary. It may change over time once we get more men to fill out the survey. So take anything I say with a grain of salt, please, because it's really preliminary, and I really want to be able to generate more in data. But this is just a sneak preview because you guys are my favorite people, okay? So now to dive in, just looking at kind of a map of those that filled out our survey, what kind of treatment did they have and where are they living? So we have color-coded on the bottom. Green is surgery, yellow brachytherapy, that purplish color active surveillance, etc. So you can kind of see, yes, they're obviously grouped around the hubs of cities, and we can actually zoom in. So 12% of our respondents are from Seattle proper, with 54% coming from the greater King County area. 5% are from Tacoma, 4% are from Olympia, and 14% came from Spokane. But this is kind of what probably a lot of you guys want to know about, which is who had the best self-reported quality of life. So I'm going to orient you to this slide. We're going to first talk about urinary function, I'm going to be using the same color code system for the rest, so I'll take my time with this first slide. I've been using the idea of green meaning good, yellow meaning caution, red meaning potentially a problem. And what I've done is on the very left is where I've stacked the highest percentage of men of that group responding either no problem or very small problem. So for example, those who had proton beam radiation, 88% reported that they had no or very small problem with urinary function. Similarly, those who had surgery, 84% of our population reported little or no problem with their urinary function. Next, we looked at bowel function. So same model. On the very left, those with proton beam radiation, 100% reported little or no problem with bowel. However, something to note is that across the board, everyone's function was pretty high. So this is all relative, but in general, most people didn't report problems with bowel function in our population. So next we get into two different measures of sexual function, and this is where obviously we're coming into bigger self-reported problems. So what you see here is on the very right, 62% of those who had proton beam radiation reported good sexual function, but that number in red, that 25% reported very poor to no sexual function. Next is, again, brachytherapy, IMRT, external beam, and surgery. So this is a report of just sexual function, but this next slide is actually looking at sexual bother. So regardless of whatever sexual function you have, how bothered are you by your sexual performance? And so again, on the very right, 63% reported little or no problem. However, 13% reported big problem. Next, brachytherapy, then external beam radiation, IMRT, and finally surgery. So kind of taking all of those different side effects in total, we kind of asked, how satisfied were you with the treatment that you chose to have? Overall, I think most people were pretty pleased with the the treatment that they had. Again, on the right, 100% of people who had proton beam radiation were extremely satisfied. 90% of those with IMRT were extremely satisfied and or satisfied, down to surgery, brachytherapy, external beam, and I even included active surveillance on there as well. So let's take all of this in summary. This is a graph summarizing all the results I just showed you. So something to note. Remember when I said earlier that some of these treatment buckets are really small? Proton beam radiation, only 8 people completed the survey. But I included it for one reason alone, which is that across the board, they reported the highest function, satisfaction, everything. They were some really happy patients. So I included it. A lot of grains of salt there because there are only 8 people that responded. So across urinary bowel, both measures of sexual function and satisfaction, relative to everything else, they were the most satisfied. Next, looking at surgery patients, they reported some of the best urinary and bowel function, but some of the worst sexual function. At the end of the day, I think they were kind of in the middle about whether or not they were satisfied or not. But again, we had 130 people fill out this part of the survey, so we can probably be a bit more confident in this data. So next, external beam radiation, kind of in general moderate urinary bowel and sexual function, kind of in the middle, but in general reported actually some of the worst satisfaction with their treatment out of 23 patients. For brachytherapy, also 23 patients, and again, better than average sexual function, maybe below average urinary and bowel function, below average